Hi, I'm Zach. I'm a master's student at the University of San Francisco. For the past 8 months, I've been collaborating with Leo Liu, professor at UCSF, and Andrew Shaw, researcher at USF. Our research problem is on the early prediction of hospital-acquired sepsis. More generally, sepsis is when the body's response to an infection goes wrong and begins to injure its own tissues and organs. It is the most common cause of death in a hospital and costs over $15 billion annually to the U.S. healthcare system. The goal of early detection is to identify patients at risk of developing sepsis as early as possible to assist in clinical decision-making processes. Every hour of delay can lead to a 4% increase in mortality rate. This is an ideal problem for machine learning because it's impossible for physicians to look at all patient trends for all hours of the day in a hospital. With the problem laid out, this presentation will highlight some of the novel additions we've made to sepsis prediction research. Previous research has been conducted on data sets like MIMIC3, which only contains data from the ICU. Because patients are monitored more heavily in the ICU, it's rare for a physician to not identify a patient with sepsis. This is in contrast to when patients acquire sepsis over a longer period of time on the hospital floor. This hospital floor setting is where the real need for a sepsis monitoring algorithm is, because patients are not checked as regularly. This is the reason why we're focusing on hospital-acquired sepsis as opposed to community-acquired sepsis. Community-acquired sepsis is when a patient develops sepsis before admission to the hospital, and it's the more common case of sepsis. However, hospital-acquired sepsis has higher mortality rates, costs, and length of stay than community. By focusing our model on hospital-acquired sepsis, it can be more effective in the hospital floor setting. In previous papers, the outdated Sepsis 2 definition has been used. Sepsis 2 is not ideal because it captures a larger population who aren't at high risk for morbidity and mortality. Sepsis 3 is the improved clinical definition. And we're using a definition from Ree's 2017 paper that is a subset of the improved Sepsis 3 definition. This is because the original Sepsis 3 definition requires the use of lab values not frequently collected in many EHR systems, including ours. To identify hospital-acquired sepsis, we're only looking at patients who have stayed in the hospital more than 2 days. We're using Ree's definition to label each septic patient at the hour they acquired sepsis, the onset time. For training data, we then include 23 hours before and 12 hours after onset time for a total of 36 hours. The chart shows an example septic patient's vital signs and labs, and their onset time labeled with the black vertical line at 105 hours since admission time. For the non-septic patients, we ignore the first 48 hours of admission to control for hospital-acquired sepsis, and then take a random 36-hour window for training data. Looking at our complete data set, we are including the last 5 years. This data set has over 92,000 inpatient encounters. To compare, datasets like MIMIC have around 40,000 encounters over an 11-year time span. Our prevalence rate for hospital-acquired sepsis is around 5%. We're using 2015 to 2017 as our training set, 2018 for validation, and 2019 as our test set. We frame our problem in a machine learning context as a multivariate time series classification problem, where we're giving a prediction for sepsis at each hour. On the left, we have our previous chart. On the right are the labels for that patient, with zeros representing non-sepsis and ones representing the onset of sepsis. One of the areas that has been absent in previous research is feature engineering. For our non-deep learning models, we're looking at trend features like slope, derived features like shock index, as well as other observational data like level of consciousness. Perhaps the greatest challenge with EHR data is the large amount of missing values for labs and vital signs. Futomo's work has shown the effectiveness of Gaussian processes for this problem. Gaussian processes are a tool that allow us to model nonlinear functions and also provide uncertainty values for predictions. Pictured is a patient's observed temperature, denoted by the black points, and a single Gaussian process approximation in red. To extend this to multiple features, we use a multitask Gaussian process for imputation. The advantage of using a multitask Gaussian process over a single task for each feature is that a multitask Gaussian process can incorporate covariances between features to model multiple features simultaneously. On the left, we have our raw features with missing values, and on the right, we have our features after the Gaussian process, where they are standardized and imputed. To compare our predictions around onset time to non-septic patients, we need to create a pseudo-onset time for the non-septic patients that's realistic. We use a technique that Futoma employed called case control matching. The process involves matching a septic patient with a number of non-septic patients, then using the same percent of time that septic patient had until onset on the non-septic patients. In our case, we matched each septic patient with 16 non-septic patients. For example, if a septic patient's onset time occurred 25% of the way through admission, we labeled the matched 16 non-septic patients 25% of the way through their admission time also. Now for our results. These results are from our validation set. We're using both area under the ROC curve and area under the PR curve. These are overall metrics, which means we're looking at every hour there is a prediction to be made. For the ROC curve, gradient boosting trees were the top model, while for the PR curve, the multitask Gaussian process, recurrent neural network, performed the best. What is arguably more important to assess is the performance before onset time. In order to ensure our classifier identifies the patient before they acquire sepsis, we look at ROC curve and PR curve as a function of time. Here we see the gradient boosted trees are performing better closer to onset time. For the PR curve, the RNN outperformed the tree-based models, but notice the random forest is not far off from the RNN. For our problem, area under the PR curve is a better metric compared to area under the ROC curve because of the low prevalence of most medical conditions, including hospital-acquired sepsis. A value of 0.6 at 4 hours before onset time is state-of-the-art. Our AUCPR reaches around 0.67, setting a new state-of-the-art, in addition to using a more clinically relevant definition. Another area not focused on in previous research is identifying feature importance. For the random forest, some of the top features identified included our engineered features, like 72-hour slope for heart rate. Some of the top raw features identified include venous blood gas lactate and respiratory rate. Hours since admission is the most influential because it allows the model to understand the time-based aspects of prediction. By identifying which features are contributing to our model's decisions, we can drop the noisy features and understand if our model is learning the correct signs associated with sepsis. We're currently using feature importance and feature selection algorithms to improve model performance. To conclude, I want to stress that hospital-acquired sepsis is the more clinically important problem to address compared to community-acquired sepsis. Our findings suggest that tree-based models with expert engineered features can rival state-of-the-art deep learning techniques. An advantage to using tree-based models is that it allows us to investigate feature importances, providing insight for model tuning and explanations for predictions. We hope our framework points the way towards creating context-specific models in the healthcare space. Thank you for listening.